Good morning, everybody. Today we are continuing the second part of the endocrine disorder. In the endocrine disorder 2, we are normally discussing about the adrenal insufficiency and the management. The learning outcome is same as the previous class. So, adrenal insufficiency. Taking a rough idea regarding about the anatomy and the physiology. You already know the adrenal are very superior about the kidney. So the adrenal cortex produces a series of steroids that mainly of hydrocortisone, glucocorticoid, and mellitus. That is called cortisol, corticosterone, and aldosterone. Corticosteroids are the essential part of the body response to the stress such as trauma, infection, general anesthesia, and the pain, stress, fever, pains, and the hyperglycemia. And next is the aldosterone. Its production is regulated mainly by the renin-angiotensin system. Renin-angiotensin system and the renal blood pressure and the sodium and potassium levels. Aldosterone acts on the kidney to promote the sodium retention, potassium excretion, and the fluid retention and cause the vasoconstriction and the thirst. So, how will it act? That is called a hypothalamic pituitary adrenocortic axis. In the brain, we already know there is hypothalamus, pituitary. Hypothalamus, they are releasing cortico-releasing hormone that induced by the sleep, stress, and the circadian rhythm that stimulates the pituitary gland to produce adrenocorticotrophic hormone. So, adrenocorticotrophic hormone that release the adrenaline to produce the steroid, but there is a negative feedback. If there is a production of steroid, no, we want to control, so there is a negative release from the adrenal gland that is called cortisol that released to the message given to the hypothalamus and the pituitary gland. Adrenocortical hyperfunction. So what will happen if there will be excessive production of the adrenal gland steroids? So the release causes the glucocorticoids that called Cushing disease, mellitus that will form the concentrated of the hyperaldosteronism, so androgen by the congenital adrenal hyperplasia. Adrenocortical hyperfunction means that reduce the secretion. Now what will happen? There will be three main things. Primary hypoadrenocorticism, that is called acute by the adrenal disease. It's the acute onset. Secondary by the there will be a systemic use of corticosteroid, the long time use of the steroids, and also by the congenital. It's by from the congenital development of the corticosteroid hyposynthesis. Next, we are going for the what are the clinical features we can see in the hyperadrenocorticism. Main clinical features we can notice is the weakness, weight gain, technical obesity, hypertension, criticism, euphoria, cutaneous strain, sanitizer, mood changes will be there. These are the main clinical features we can notice in the hyperadrenocorticism. And going to the hypoadrenocorticism, there is anorexia, anosmia, vomiting, hypotension, skin and mucosal pigmentation, weakness, and the weight loss. Now, going for the Cushing disease. It is due to the excess production of the glucose by the adrenal hyperplasia secondary excess of adrenocorticotrophic hormone. Cushing disease is a secondary to the pituitary gland disorder. Cushing syndrome is caused by the primary adrenal disease. Mostly, you can see the Cushing syndrome has been found due to the micro-adenomas to the pituitary. Just to call the synonymous Cushing syndrome and the Cushing disease. Cushing syndrome. So, what are the main medical diseases we can see in the Cushing syndrome? There will be the government, and also the face becomes the bone face, and the facial photographs we taken from the past and the present, there will be lot of difference will be there because of the fatter position, and also there is intercapsular region we can say buffalo gum, triangularity, and sparing of the limbs. And hypertension is the common one. Breakdown of the proteins, the conversion of the glucose that will leads to hyperglycemia, means increase the blood sugar level, and there will be possibility of the diabetes mellitus. And also we can see the osteoporosis, muscle weakness, thinning of skin, purpura, and brush the skin dry. Other clinical features we can see the autism and acne, oligomenorrhea, infection, and psychosis. These are the main, other than the main clinical features. Core syndrome is the primary hyperaldosteronism. Addressing of the adrenal cortex being tumors of the hyperplasia. So we can see the potential are called hypokalemia, weakness, cramps, paresthesia, polyuria, polydyspnea, tetany, hypertension, and the sodium retention that causes the hypertension, but is very rarely in the edema. So, what are the main things we are noticing for the dental management? These are the most clinical features we can see. If you're going for the dental management, what are the pain control, LA, and sedation we can give. Hypertension and cardiovascular we can notice. So we want to reduce the hypertension, that is much more, and there will be chance of the diabetes mellitus. So we manage according to psychosis. And corticosteroid cover if the patient having history of bilateral adrenalectomy, because we are doing that, there will be chance of corticosteroid coverage will be needed. So otherwise there will be risk from the process of dental treatment. So causes for the adrenal insufficiency. In the adrenal insufficiency, there are three main things: patient on systemic steroids, and adrenal disorder will be there, and the hypopituitarism. These are the main causes for the adrenal insufficiency. Systemic steroids, like we're going for the mainly on the trauma, depression, and infection like that. No? These are the main things for chronic systemic steroid. Adrenal disorders like Addison disease, post-adrenalectomy, and what else was the malfunction syndrome, and congenital adrenal hyperplasia. These are the main adrenal disorders we can see. Next one is the Addison disease. Autoantibodies of cause adrenocorticotrophy and failure to the hormone secretion. So that will lead to Addison disease. So what are the conditions for the use of systemic steroid? The adrenal insufficiency, that will be Addison disease, adrenalectomy, and hyperpituitarism. There will be deficiency of the steroid. Allergic disorder like asthma, blood disorders like the idiopathic thrombocytopenia, lymphocytic leukemia, lymphoma, connective tissue disorder like rheumatoid arthritis and systemic lupus erythematosus, gastrointestinal disorder like ulcerative colitis and Crohn's disease, mucocutaneous disease like pemphigus, post-transplantation like any organ transplant like kidney, everything, renal disorder like nephrotic syndrome and the renal transplants. These are the main things we can see the so what are the main complications we can see if you are going for the corticosteroid, cardiovascular, that is cerebrovascular accidents, hypertension and myocardial infections. Dermatology we can notice acne, bruising, reason, striae. Gastrointestinal like ulcer, immunosuppressor like increased susceptibility to the infection will be high chance of infection and the person for a long time. Neurological like cataract, mood changes and psychosis. Metabolic like fat reduction that already we told moods, face or buffalo horn. Growth retardation, hypothalamic pituitary adrenal suppression, impaired glucose tolerance or diabetes mellitus, loss of sodium and potassium, that only hyperkalemia like that, muscle weakness, osteoporosis and weight gain. So what we'll do for a long steroid therapy the patient is taking for a long minimum around 1 year, more than 1 year like that. There will be no any contraindications for but mainly what will happen there will be we want to reduce the hypertension and the diabetes will be there, so we want to control the hypertension, manage the hypertension and diabetes we can control, reduce the blood sugar we can do it. The smallest effective dose, steroid dose should be given based on the morning or the alternate days. Systemic steroid causes a greatest risk of adrenocorticoid suppression, so topical steroids can be preferred. The patient can give a warning or told to the dangers of the withdrawal and side effects. And weight and chest radiography or bone mineral density, blood pressure and blood glucose baseline measurements should be taken and monitored. And if the patient has the peptic ulcer, this problem will be there, so we give adrenocorticotrophic can be cured. Otherwise, there will be high chance of ulcerative colitis because severe gastritis will be there. Next one, adrenal suppression. So suppression may already manage the hypothalamic pituitary adrenocorticoid axis due to the long-term steroid treatment or the dose of steroid psychology. That means we can think about that the patient is taking 75 milligram per day of prednisone or patient is currently taking a systemic steroid like more than 5 milligram prednisone. So you memorize that thing. The patient is taking more than 5 milligram or 7.5 milligram prednisone per day. So you must careful. It is very important. And the corticosteroids having been taken regularly during previous 30 days. Means the patient is taking continuously of the steroids for that day and steroids are taken for more than 1 month for the during the past year. So you must trigger this patient taking steroid for a long time. What are the stages we can see in acute adrenal crisis? So it will be already we can get the past history. Then what are the things we can notice? So when there is a collapse, there will be reduced BP, then hypotension, profound weakness and lethargy, weight loss, and anorexia, nausea, vomiting, diarrhea, and dizziness. These are the clinical features we can notice in the acute adrenal crisis. So, what are the suggestions for the patient if the patient is taking it for a long time steroid therapy? So, what are the management we can do for that type of patients? So, that is very important. The main thing because in this we are doing the long term steroid. Now, what are the things we will do? because in dentistry we are doing lot of things like conservative management, conservative dentistry, and the extraction and the periodontal treatment like that. So there are three types. There will be non-steroid for the previous for 12 months, steroids taking during the previous 12 months, steroids currently they are taking. So what you will do in the conservative dentistry and the for a single tooth extraction and rarely, if there will be no steroid for the past 12 months and there will be no any coverage, we can do the procedure. But if the steroids are taking for the past previous of 12 months, what will you usual oral steroid dose in morning, that means around 10 milligram of prednisone we can give, or hydrocortisone succinate 25 to 50 milligram IV preoperatively. So that means either we can give 10 milligram of steroid prednisone we can give on the morning before procedure, or hydrocortisone 20 to 50 milligram IV preoperatively. Steroids are taking then double the dose. That means prednisone normally they are giving around 5 milligram, that 5 to 10, that will increase to 20 milligram of dose on the preoperatively, or hydrocortisone 20 to 50 milligram IV, orally or IV, and continue normal steroid medication postoperatively. That means already the patient is going currently on steroid, then before the procedure we will give a prednisone to 20 milligram, and after the procedure ask the patient to continue his normal medication. If the patient is going a multiple dose of exertion under GA or a normal procedure, what we'll do? First, we consider cover if the large dose of steroids are given to them. Test first adrenocortical function stimulation test we will do. If the patient taking procedure of 12 months, give the oral steroid prednisone 10 milligram in the morning plus, that is plus hydrocortisone 25 to 50 milligram IV priority, and 6 hourly for 24 hours will give the steroid. If the steroids they are taking currently, they are taking double the dose 20 milligram in the morning plus hydrocortisone 25 to 50 milligram IV priority, and 6 hours for 24 hours, then continue the normal medication. So if the patient have a maxillofacial trauma, it's a going for a major surgical procedure, what we will do? Consider if the larger dose of steroid were given, test of adrenocortical function, that means stimulation test will do. Steroids they are taken previous 12 months. Usual oral steroid dose in the morning plus hydrocortisone 20 to 50 milligram IV periodically, and 6 hours for 72 hours. For minus to 24 hours, so 72 hours. Next, steroids are currently taken double the dose of oral steroid in the morning plus hydrocortisone 25 milligram IV periodically, and 6 hours for 72 hours. Then only we can continue the normal medication. This is routine regimen for the steroid going for the single tooth or the dental procedure, like going for a normal restoration or bilateral surgery. This is by heart. Then pheochromocytoma is like a rare tumor, most common in the adrenal medulla, but the others arise in the neuroendocrine tissue and produce norepinephrine or dopamine. So the management is acute hypertension as may complicate the then reduce the hypertension. Elective treatment should be deferred until after the surgical treatment of the pheochromocytoma. If the emergency is required, the blood pressure control by the alpha and the beta adrenal blockers. Mostly we are giving the propranolol, so we can reduce the blood blood pressure. These are the mostly using medication for the hypertension. Next we are going for the thyroid glands. What are the functions of thyroid? Mainly regulating hypothesis via the effects of the gene transcription of messenger RNA stabilization, the sensitivity of tissue to catecholamine, mitochondrial oxidative activity, synthesis and degradation of proteins, differentiation of muscle fibers, captive growth of cells and the antioxidant. Next one is the goiter that already we know in the cell surgery. Goiter is enlarged by the thyroid gland. What are the main causes? No? There are psychological, low adenine drugs, and thyroid disease. Psychological by puberty, pregnancy, low adenine with take off, adding endemic goiter called low adenine intake. The drugs inducing the goiter except thyroglobulin, cortisol, potassium perchlorate, lithium, phenylbutazone, and thyroid disease like Graves' disease, carcinoma, Hashimoto thyroiditis, and dysgenogenesis. Next is the hyperthyroidism and hyperthyroidism. So, the hyperthyroidism, the main clinical features we can see is dry and coarse hair, loss of eyebrow hair. The eyebrow hair will be fall, puffy face, enlarged thyroid, that is goiter, and slow heartbeat. And the main clinical features in the hypothyroidism is arthritis, cold intolerance, depression, dry skin, fatigue, fatigueness, heavy menstrual periods, infertility, and muscle aches. These are the main clinical features we can notice in the hypothyroidism. And weight gain, constipation, and brittle nails. If you're going for the hyperthyroidism, hair loss, bulging eyes, sweating, enlarged goiter, and rapid heartbeat. In hyperthyroidism, in this means rapid heartbeat. And the main clinical features is difficulty in sleeping, heart intolerance, infertility, muscle weakness, neuralgia, and scan menstrual periods, weight loss, frequent bowel movements, warm and moisty palms, tremor on the fingers, and soft nails. These are the main clinical features we can see in the hyperthyroidism. So, going to the dental aspect, what are the clinical features we can notice in the hyper and hypo? In hyperthyroidism, we can see the accelerated dental erection in the children, maxillary and mandibular osteoporosis, and enlargement of the extraglandular thyroid tissue. Susceptibility to the genes, Brown disease, burning mouth syndrome, and connective tissue disease, that is Sjogren syndrome. So, hypothyroidism we can see delayed eruption, enamel hypoplasia with the both dentition, anterior open bite, macroglossia, micrognathia, thick lips, then distortions the sense of the taste, that's called dysgeusia, and mouth breathing. These are the clinical features noticed in the dental aspect. So what we'll do in hyperthyroidism, the main dental aspect, what are the main things we'll do in the hyperthyroidism? If you're going for a treatment, normally we are irrigated with the povidone. So there will be high risk in the hyperthyroidism that will increase hyperthyroidism and may lead to thyrotoxicosis. So avoid povidone added irrigation on for the hyperthyroid patient. And drugs which may precipitate mixed edema, coma, like sedation, midazolam, open analgesics like codeine and tranquilizer. Next is parathyroidism. Already we know the parathyroid is situated below the near to the thyroid gland. So when you're going for the thyroidectomy, the parathyroid also go up. So what are the main things? There will be present like primary, secondary, and tertiary. In primary, caused by the parathyroid adenoma, seen in the postmenopausal woman, rare causing includes the carcinoma of the parathyroid. In secondary, the response to low plasma calcium level caused by the chronic renal failure or prolonged dialysis and severe malabsorption. In tertiary, follows prolonged secondary hyperparathyroidism which was because autonomous. So, what are the clinical aspects we can notice in the hyper and hypoparathyroidism? In dental aspects, the while the pulp chambers and development defects, alteration in the dental eruption, weak teeth, malocclusions, and there is one called the brown tumor, giant cells lesions of the jaw, and loss of bone density, soft tissue calcifications. These are the main things we can see in the dental as well in the hyperparathyroidism. If we're going for the hyperparathyroidism, we can see enamel hypoplasia in the horizontal lines, poorly calcified dentin, widened pulp chambers, dental pulp calcification, shortened roots, hypodontia, delay of the dental development, mandibular torre, chronic candidiasis, paresthesia of the tongue and lips. These are the main things we can notice in the patients. And the next one is called the there is the coexisting and Torshustein. The Torshustein and Torshustein is due to the hypoparathyroidism. So the removal of the hypoparathyroid removal, no, there will be contraction of the facial muscle upon tapping on the facial. So the low plasma calcium leads to the muscle irritability and tetany with facial twitching. Already you know that there will be hyperparathyroidism, so that's functionally similar to calcium and plasma. So the level of the calcium level that will lead to muscle irritability, that's called surface on the facial upon the face. Torsion is a contraction of the hand and the fingers. So how we can see the torsion? Torsion you can see in the picture. The hand, the carpal spasm involves the adduction of the thumb over the palm, followed by the flexion of the metacarpal ligament joints and the extension of the interphalangeal joints and fingers together, adduction of the hyperextended fingers and flexion of the wrist and elbow joints. So a similar effect occurs on the joints or joints of the feet. This is called carpal spasm. So this is called a torsos sign. If we going for the Shakti sign is we can check out the facial nerve. What we'll do, telling the patient to relax his facial muscles, then stand directly in front of him and tap on the facial nerve either just anterior to the earlobe and below the zygomatic. You already know the facial main trunk goes anterior to the earlobe. There are 5 branches. So we are going between the zygomatic and the corner of his mouth. There will be a posture response waves from twitching of the lip at the corner. You can see in the diagram the patient lips at the corner of the mouth to spasm of the facial muscles depending on severity of hypocalcemia. So these are the two clinical signs we can see in the hypocalcemia, that is due to hypoparathyroidism. One is torsion, the contraction of the fingers, next, and the Schefter's sign. So that we will tap on the main trunk or on the branches of the facial nerve. So the what will happen? There will be corner of the nerve will be going spasm. So these are the main clinical features we can notice in the hypoparathyroidism. Thank you. So in this topic, we are talking about the adrenal insufficiency, thyroid gland, and what are the main things we can notice for a thyroid adrenal. If the patient is taking a long-term steroid, what are the main things we can notice? And thyroid patients, what are the things we want to avoid, like for pituitary irrigation will be avoid. These are the main things we can manage. Thank you.